Hi, everybody. As you know, I was off yesterday, not feeling well. I still have a bit of a cough. You may hear it in my voice. If you hear me suddenly cancel out here quickly, it's probably because I'm going to do a bit of a coughing. So occasionally you might hear me suddenly just kind of disappear and come back in again. I apologize ahead for that. So our next set we're talking about here is treatment planning documentation. So we've talked quite a bit about treatment planning. Here we go. I got a cough. Just a moment. So we've talked quite a bit about treatment planning documentation and its role that it plays, or at least treatment planning in essence. We've talked about the plan of care, which is a form of a treatment plan of what we're going to do over the period of time that we're treating. And then, of course, we have the day treatment plan. So what is it we're going to do with our patient when we're actually treating them today, when they're on the table? How do we document all that? So obviously, what we want out of this is you understanding the importance of treatment planning. So it's very important to create a treatment plan and then how to develop and implement a treatment plan. I talk quite often about a treatment plan is what keeps you busy. A treatment plan is what brings you patients back over and over and over again. And if you continue to create treatment plans for many patients, before you know it, you're going to have a very busy clinic. If we remember the outcome-based massage model, we have this therapeutic relationship, this decision-making that we need to do, clinical decision-making, and of course, evidence-based practice all results in this outcome-based massage. So we have to understand that within the context of this is where our treatment plan comes from. When we look at a client in their initial appointment, of course, the first thing they're going to do is, we always talk about this, how you're going to observe when they walk in and so forth. But before the official or the formal appointment begins, we always have them fill out a health history form. Of course, we'll talk a little bit about that. And then, of course, we get informed consent, which is important, which may be on that health history document as part of it, or it may be a separate document that they sign for you while they're sitting in the room waiting to come and see you. Our intake and interview then, of course, is subjective and objective information in those pain questions. And for our purposes, we're looking at those sorts of things, and that will continue to grow larger the more you learn as you move through the program. Our assessment at this point is taking blood pressure, as I said, observations of posture, gait, and of course then muscle length and strength. And for now, that's our scope of practice from an assessment point of view. Again, that will get broader and larger as you move through the program. Our treatment plan for initial treatment then, of course, is created, and then we have our treatment that we do, and we reassess post-treatment. That could be a blood pressure, could be further observations, and so forth. And then our treatment plan for ongoing plan of care. So what we're talking about today is the treatment plan for initial treatment, and then the treatment plan for ongoing care, or the plan of care. So remember, treatment plan for ongoing care can also be known as the plan of care. So let's do treatment planning first. It's a planning document where you analyze the client's information. So, you look at that case history, you look for any identifiable things within what the patient's written down in regards to case history. So anything that sort of raises a question in your mind, or it could be that what they write in there turns out to be a bit of a red flag. Then we do our examination based on what we see in there, and including our questioning, our pain questions, and so forth, which is within our examination findings. We then take all that information together. So what's in the client information, what we have found out through our assessment, blood pressure, pain questions, muscle length and short and long and strength and so forth. And then we formulate a strategy for the client's treatment based on specific goals and outcomes, which again is part of the interview process. We keep going back to this, yes, the patient has a situation, a pathology, or a condition, but it's how that patient is affected by that condition or pathology that helps us create goals and outcomes for the treatment. The document we create is called a treatment plan for that treatment, right? So when we talk about a treatment plan, it's for what's going to happen in that hour-long treatment when they're on the table. If we're looking at a long-term set of treatments within our goals, this is known as an ongoing treatment plan or a plan of care. Let me repeat. The treatment plan is what's happening when you're working on the client for their hour treatment, whereas the long-term set of treatments to achieve the long-term goals are known as the ongoing treatment plan or the plan of care. So I guess the question is, why do we need a treatment plan? What is so important about a treatment plan? The first is when you are creating a treatment plan, you're performing it or you're creating something that is specifically related to the client that you're seeing today. I can't go on enough about how important it is to recognize that yes, there's a pathology or condition, but it's about the individual. So when you create a treatment plan, it's about dealing with whatever their condition is they're coming with as it relates to them and their needs. As I said, it helps identify the goals for treatment. So, once you get a sense of things, then you know where you're headed, and so too does the client. That's what's important to understand, is that you're working together, that working through the client, you know what direction it's going and what the outcomes are from your treatment, and the client is also very aware of what's going to happen and what you're trying to move forward to attain. It also ensures that the therapist works to achieve your client's goals. So by identifying your client's goals, you as the therapist then are working towards achieving said goals with the knowledge of the pathology they may be presenting with, the exercises that need to be done, the appropriate techniques, and so forth. Quality assurance. This helps with us making sure that we are ethically giving what the client needs and we are giving them the most quality treatment for positive outcomes that we can possibly give. So without these key planning pieces, we'd be massaging with a trial and error approach. Obviously, this is not anywhere near effective as that, and it can cause damage or take more time in the long run. I mean, you can see here this picture of this building that looks like it's going to fall down at any moment. Someone just kind of put it together piece by piece without, any sort of thoughts of how we're going to move forward. It's exactly the same with us. Now, I've told you guys in class, I would never treat a client until I assess them, which of course is part of conversation, understanding how it affects them, what their goals are, and so forth. So I will not treat a client until I have assessed them to the best of my ability. And as I've said many times with you folks, where you're at in your assessments will change as you move your way through. It just will get larger and larger and more diverse in terms of what you're looking for and how you're assessing your clients. But fundamentally, you must do this. You cannot treat a client without doing an assessment. And that assessment also ensures that you're creating an appropriate treatment plan to meet the goals of the client. If the client's goals are met, they are a satisfied client. They're very happy with what you've done, and they're going to recommend you. And of course, the one thing we all want to be is busy if we can. The foundation of the assessment and plan allows us to focus on detail tailored for the individual and the client's benefits. We treat the root cause of their complaint and have a more efficient treatment. So we can see, if we compare this to this, it's quite obvious that by working on assessing, understanding how to do something, maybe this is a house that was created for a client who knew exactly what they wanted. The architect or the gentleman or woman who does the building, contractor, they're able to design something like this for the client based upon their needs. Everybody's happy. It assures good quality, and everybody walks away satisfied with what they came into in the first place with the relationship. So when we look at this evaluation, treatment, planning, treatment, we've talked a lot about the evaluation, which of course, understanding why the client's seeking treatment, creating or finding subjective and objective client information through examination, and analyze those findings and confirm the client's presenting issue. Again, walks like a duck, talks like a duck. You assess to see if it is a duck or not. What we're talking about in this set of slides is the treatment planning, which is identify the client's impairments, wellness goals, and specify outcomes or specific outcomes. So what are those? And then selecting the appropriate treatment techniques and creating the plan of care. So a couple of things in here. Identifying. Of course, we can't identify the impairments that a client has until we discuss those with the client and get a sense of how their presentation is affecting them, and then what they're looking to get out of the treatment and the rest of their life, whatever that may be, back to normal or maybe with alterations based upon what their issue is. And of course, then once you have a sense of all that, and I talked about this last week, you then look into your tool belt and see what tools that you have to achieve those outcomes for the client. and you apply them appropriately. Now, the one thing about doing this as well is, and I've said this before in regards to the scope of practice, you only have so many tools in your belt. As you move through the program, you're going to gain more and more tools in that belt. It's also up to you to take the time to recognize that what you have in your belt may not be able to provide what's required for the patient or the client to achieve the outcomes. So this is when we refer out. Could be that another massage therapist in school here, for example, that has more education in their background. They're more of a senior student in the program. Or it could be that you are now a massage therapist and you're recognizing that the condition is better treated by a different healthcare practitioner, and you're going to move them accordingly. This is the reason why you're doing that assignment that you're doing for me, is to try to get a sense of scope of practice of other professions, so that, again, through your assessment and trying to decide what appropriate techniques would be to create or to have the client meet those goals, or you meet those goals with the client, that may include someone that's a different profession. So when we look at the steps in the treatment planning phase, we want to, again, identify the client impairments, their wellness goals, and specify outcomes, for example, the goals of treatment. And then we select the appropriate treatment techniques and create the plan of care. Remember, the treatment plan is what we're going to do today, and the plan of care is the number of appointments it's going to take to achieve the outcomes at the very end. So when we look at the standard for a treatment plan, we have to consider what the CMTO lays out to be appropriate in a treatment plan. So if you are ever audited by the CMTO and they're checking your paperwork to make sure you're doing things correctly, these are what are required on a treatment plan in your charting. So the first is the goals, both you and your patients, which of course you're working together. The type and focus of the treatment, deep work, remedial exercise, whatever it may be. The area of the body to be treated, back, shoulders, head, neck, gluteals, and so forth. Frequency and duration of treatment. So is it going to be 1 hour of massage a week for 2 weeks or 6 weeks, or 2 30-minute massages for 4 weeks, and so forth? Your anticipated client's response to the treatment. The schedule to reassess, so usually we do that within 4 to 6 weeks, so you would always put at the end of your treatment plan the period of time that treatment plan will run. In most cases, 4 to 6 weeks, which then you would do a reassessment. And then, of course, the recommended REMX or hydrotherapy, and that could be many, many things: hot, cold, warm, cool, stretching, strengthening, so on and so forth. So remember that when you're going into treatments in 2 semesters, and what you're starting to learn now in your classes is your ability to be able to do what is called a wellness treatment or a wellness massage. So let's review the goals for said wellness massage. So when we look at journal outcomes and goals, these are things to consider, but aren't just limited to these. Again, as things move on and you learn more, there may be some other considerations. But for our point right now, for wellness treatment or a wellness massage, we want to either increase or decrease sedation. We want to either increase or decrease alertness. Sympathetic nervous system firing. Now understand that the sympathetic nervous system has 2 portions to it: rest and digest, and fight and flight. So obviously, depending on what we want, we may want to stimulate that parasympathetic to slow down the sympathetic situation that's happening, and we can affect that. We want to change muscle resting tension. We have to remember, again, from sedation versus stimulation, right? Thus, we have to think of both directions here. We want to affect circulation. We might want to affect lymphatic return. We definitely want to change perception of pain, depending on where they're at. We don't ever want to necessarily lock ourselves into a 0. It would be great if we could 110% remove someone's pain, but again, I've talked about this in class before. We have to be aware that that may not happen because pain is subjective. But certainly we want to change their perception as much as we can, and want to change mood and anxiety. And there is a lot of research out there that shows that with that, that relationship between the immune system and mental health we can, through sedation and lowering anxiety and so forth, actually improve immune function. We have to consider the intake when we do these, the results of assessment, the treatment planning, and the record keeping. These are all as valuable as the time you spend actually with hands-on when you are treating your client. So these are as valuable as the time you spend actually hands-on during massage treatment and are part of the treatment time your client books with you. This is your challenge. Far too often, the general public thinks that all they do is they pay their money and they get on the table for 60 minutes and we're going to make them feel good. Many do fail to realize how important it is for us to assess them to get a sense of what their goals are, and that if we actually took the time to do that, we would be far better prepared to meet their goals and they would be much more satisfied with the treatment they're getting. So your goal is to always inform patients as best as you can to get them to understand this part of what we do. So again, we're looking at, we've gone through health history document, it's been done. Informed consent sheet has been done. We've done our intake, our interview. So we've looked at subjective and objective information. Again, clarifying possibly the health history document, the reason why they're here, what's going on. The pain questions, how, when, why, where. And then our assessment, and again, for our sake, blood pressure, observations of posture, gait, and then we look at muscle length and strength. And then, of course, our treatment plan for initial treatment is what we're creating here. And then we get the consent to that initial treatment that we've created. So, it's sort of like, what is our choreography going to be today on our client when we're trying to meet the goals and outcomes for this appointment? So I like to use the term sort of choreography because it's in fact what we're doing is, again, that tool belt, looking at the tools, what can we use to affect the change of the goals? And then, of course, at the end of treatment, we're going to reassess to see what changes we've affected. Is the pain better or worse? Has the range of motion gotten better than it was? Do they overall feel less anxious today? So on and so forth. And then, of course, then we consider our treatment plan for ongoing care or our plan of care. And of course, we need to have a consent to that plan of care. In other words, they may be consenting to meeting with you once a week for an hour treatment for 6 weeks. 6 weeks for an example. So documentation in regards to all this. Well, the CMTO sets out very strong and objective guidelines as to how we document and where we document when we treat our clients, and that includes everything from the first moment they walk in the door with observations all the way to the end of the treatment for the day and the treatment plan maybe for the next 6 weeks. So your file must include, of course, the consent, and if part of your treatment plan identifies that you're working in a sensitive area, then of course following the guidelines around that sensitive area form must be filled out. It should have the health history in there that the client filled out prior to the treatment. The assessment form, so the results of your assessment wherever you are in the program, depending semester 2, 3, 4 through 6. So you fill out that assessment form. Your treatment note needs to be filled out. So what you did, how you did it, for how long you did it. What is your ongoing treatment plan or plan of care? So what is the plan for the next 6 weeks in terms of that treatment plan? And of course, the consent to that. And of course, supporting documentation such as referrals, maybe from a physician, a consent to release information. If this is an insurance case and the insurance wants access to it, of course, this is something the client approves, not the insurance company. And our fee schedule, how much we do charge. And that, if you think about it, that's part of our consent, right? I'd like to see you today for a 1-hour treatment, and the fee is $110 for that treatment. Going back to informed, we're informing them so they can give consent to what we're going to do with them. So our health history, again, we obtain, update, and record that health history. It is minimally done every year, no matter what. We're always looking at if there's new medications, that goes into the new health history. Any changes in health, injuries, surgeries, or babies also changes the health history, so we have them redo it. And any change in address, name, or billing information also requires an updated health history. So new medications, changes in health injuries, surgeries, babies, and change in address, name, or billing information all requires an update in the health history form. Our assessment, of course, again, we determine the client's condition by conducting an assessment reassessment. So their condition assessment before they do the treatment, and the condition of our client after the treatment is a reassessment. This is interview and pain questions, blood pressure, posture, gait, range of motion, the joint that you've identified, right, left, or bilateral, muscle length and strength testing, and of course our palpation, our 5 T's, texture, tenderness, tone, tension, and temperature. So they all have to be within the documentation of that assessment. And of course, this changes as you move through the program. These sort of represent what you're kind of doing now. Now, let's review the treatment note and treatment plan documentation. The purpose of these is twofold. Is one, if one wants to look back, what did we do last year, Mrs. Jones? But the second thing is, let's say you got pregnant and you needed to do a pregnancy leave and someone was coming in to look after your patients for the year or so that you're off. You want enough details in that treatment and the creation of that treatment plan so that any other therapist who walks in can completely duplicate exactly what you were doing, especially if obviously the techniques you were using and the outcomes you were trying to achieve were met. So we certainly wouldn't want another therapist coming in doing something entirely different that may not work. We want details so that someone can walk in and completely duplicate exactly what you did. When we do treatment notes, we can use that medical short forms, which I did give out there a few weeks ago, or is in Blackboard. These are the standard massage and Georgian short forms, so they do expedite your ability to be able to create a treatment note, speed things up so that it's a little bit better and everybody knows what they mean. Also answer who, what, where, how, and why, and recommendations. This is how we sort of compile our information is who, patient or you, what, where did you do it, how did you do it, and why did you do it. The other thing is you want to put in there is your clinical impression. So of course we cannot diagnose. We can have someone come in and we may have a very, very significant idea as to what's going on with them. They may even come in with a diagnosis from a physician, which of course we would include in our charting. But fundamentally, as a massage therapist, all we can do is state our clinical impression. So that is based on the client information, your observations, assessment, and evidence, right? So it's, again, just a clinical impression, not a diagnosis. So let's walk through an example. Your client, Dave, works as a computer engineer. The primary complaint on the health history form is neck pain. He's a very tall man and notices his neck pain is aggravated by looking down at his computer and the robotics that he works with at work. There are no contraindications to treatment, and the client is in good overall health. So I'd like you to take a moment, stop the slides here for a moment, and write down what that means. Where are the key points here that you need to consider right from the get-go? So at this point, you've got a health history form, and that's it. And there are some key components here that you need to consider within that health history form, which then should start you down a particular path. So stop it for a moment, sort of reflect on it, give yourself a minute or two, and then come back to the recording. So intake. Well, must we remember to tell the client about gathering information for the health history in the intake process? What's vitally important is that this is necessary for you to create an appropriate treatment plan to meet the needs of the patient, and that whatever you take is always confidential under the rules and regulations and legislation in Canada. So anything that the patient says to you is kept confidential. The other thing you need to let them know is what you're going to be gathering during this process. So things like intake questions to help clarify the case history form and pain questions. So within those intake questions, if we go back here again, stop the slide for a moment and try to consider some intake questions that are outside his case history or his health history form. Obviously, there are no contraindications and he's in good overall health. So obviously there's nothing really sticking out. But in regards to things to consider, give you a couple of hints. His neck pain. And there's a particular position that he's in when he gets this neck pain. And ask yourself this, that position and his neck pain, what could be occurring and what sorts of things could you do to help him with it? So again, stop the recording for a moment, reflect on this, and then move forward again. The other thing is consent. So we need to consent and reassess. So, we're going to be doing an assessment, so we need consent for that. So when we're thinking of that, we have to consider all of these points. The nature and purpose. What's going to occur during the assessment, the areas that are involved in the assessment, and identifying the source of the problem. Are there cautions and contraindications? If there are any, you need to discuss with the client. If there aren't any, then we move, that's just letting them know there aren't any. The benefits to an assessment is to deliver an effective, safer treatment and to solve the problem more quickly and more specifically. Are there risks or complications to an assessment? Yes, there are. You can cause residual pain and you may exacerbate the condition. A good kind of rule to remember is during the assessment, if you exacerbate the pain through palpation or movement, you are likely identifying the area that's causing the problem. Consequences. What kind of consequences could be possible if a patient does not have an assessment? And I think you can kind of figure some of those things out. Empowerment. The client has the right at any time to stop or modify the assessment if it's too much for them. Sometimes if they stop it because maybe it hurts too much, then have a discussion around, consent to going back to doing it more modified. Client care, of course, you'll always be checking in with the client to ensure everything's okay into what you're doing. Alternatives still relate to assessment because you may need a substitute decision maker if needed, doctor or other healthcare provider for alternate type of assessment. So again, your assessment may show that maybe it's something beyond your scope of practice. We always allow for opportunity for questions, even during the assessment. The therapist asks if there's any questions to allow, questions allowing time for that. That can be while the assessment's going on. The client may say, why are you doing that? Or it could be at the very end. And of course, then the answer to the question, do I have your consent to move forward with assessment? So what might you find when you look at this gentleman's case history? Upon observation, you may note that they have a forward head, or what we call an anterior head carriage. And we talked a little bit about that in class. Something else related to this forward head could be these internally rotated shoulders. So everything's kind of falling down and forward. In other words, what you might be seeing is that their seated posture is very, very poor. Internally rotated shoulders, increased kyphosis in the thoracic spine, and an anterior head on the neck. Range of motion, you might find changes, and in this case, a decrease in range of motion of lateral flexion away from the affected side or bilaterally. So we might be talking about the neck here because the neck is the chief complaint. So if we think of lateral flexion, if we're moving away from the affected side, why would we have a change in of range of motion decreased? Or why would we also have, in this condition, a decrease in range of motion both into the affected side and out of it? The next thing, of course, is your strength testing. So you may see that there's increased strength in sternocleidomastoid anteriorly, but you might find weakness in deep neck flexors. And it could be that, these deep neck flexors have been shortened for so long because of his head position, they become weak. This helps us in creating our treatment plan. Looking at those two structures right there, how can we affect those? What can we do to these two muscles to help affect change? On palpation, we find there is increased tone in cervical neck muscles. So what neck muscles might be affected from computer work? Would they be more anterior or more posterior? Would they be some of those muscles that we talked about last week and related to the neck muscles in clinical anatomy? So if you want, take a moment or two, stop again, Try to write down some of the results of these and what structures you think might be affected within the context of this assessment. Once we have all that information, you create a clinical hypothesis. So you say to yourself, based on forward head carriage, decreased range of lateral flexion away from it, increased strength in SCM, weakness in deep neck flexors, and increased tone in cervical neck muscles, well then, therefore, you, again, this is the example would be, my client is presenting with increased tone in the SCM bilaterally and the anterior head carriage with a 6 out of 10 pain in the neck. This discomfort is aggravated by his work, looking down at his work for long hours. This could be due to postural imbalances. And you start to move forward with this hypothesis to try to see if you can reinforce it or possibly refute it. The next, of course, then once you have an idea what's going on here, you have your hypothesis, you then think about your treatment. What is my treatment going to be today? Okay, so this is your consent to treat or your treatment plan for today. What's your treatment plan for today? How are you going to choreograph how you're going to treat this condition? What tools can you use in order to affect change here? Same idea, nature, outcome of the assessment, purpose. So, this is what I found during the assessment. The purpose of my treatment is this. I'm going to be treating this area, that area, undraping appropriately in those areas you've identified. Contraindications and cautions, that there aren't any, and if there are, of course, you would discuss them. What are the benefits of this treatment I'm going to do today? Decrease discomfort in the neck, increase range of motion in the neck, and so forth. Risk complications, what could be the side effect of the treatment? I'll let you think about that. Consequences, what could happen if they don't have the treatment? I want you to think about that as well. Of course, empowerment is always part of consent. They can stop or modify the treatment at any time. Client care, you'll be checking in with them to make sure that their comfort levels are okay. And if, of course, there's something going on, you need to send them off for an alternative care, you're going to let them know about that. And that could be even during your treatment. You notice something's going on that they need to refer out to. Opportunity for questions. You're always allowing opportunity for questions. And of course, at the very end, do you have consent to perform the treatment? So when you now are going to do this treatment, you're going to put the date, time, their name, and the cost of the treatment. How long did you treat them for? What their chief complaint was? What areas you treated? What techniques did you use? Which type? Which muscles? What kind of pressure? How fast or how slow did you go? And what kind of rhythm did you use? What position on the table were they? Were they prone, supine, or seated, semi-supine, so forth? What were your clinical findings? How did you come across your hypothesis? Well, this is your what you found with your assessment. So were there abnormal findings in your assessment? What were your findings when you were actually touching them during palpation and the treatment? So what did you feel? And what did the client report while you were working your way through the structures when you were performing the treatment? And then, of course, what was the body like? What did the client say? What kind of movements did they or did they not have post-treatment? And you'll put those changes down. So you might put in your treatment, decreased lateral flexion away from the affected side of the neck before treatment, and increased range of motion, lateral flexion away from the affected side after treatment. The client reaction, so this is tied to a pain scale or goals. For example, you decrease the pain from an 8 out of 10 to a 3 out of 10. And then you put in your home care, which in this case could be stretch, could be strengthen, education on posture, how to sit properly, how to breathe properly, and again, a back pocket thing I can have for you here. In my mind, sounds like this individual may have some ergonomic issues at their desk, and have a discussion of what their setup's like when they're sitting there and working in their working environment. Of course, we want to document this treatment plan as well. We then get the consent and then we execute it. So remember, the treatment plan is what we're doing today. We're going to consent and then execute it. So what's this treatment plan going to include? What your goal is for the day, what type of treatment you're going to do, and the focus of that treatment, what area of the body you're going to do in this treatment, the frequency and duration, so 1 hour a week for 2 weeks, your anticipated response to your treatment, and the schedule to reassess, which is normally 4 weeks, and then recommending Ramex or hydrotherapy, stretch, strengthen, and so forth. The treatment plan, again, the consent, what are the client's functional and treatment goals? So you're going to reiterate that back to them as to what the functional issues are and what their goal is in terms of getting back to function. The type and focus of the treatment. So in this case, you're going to be focusing on wellness, pain reduction, etc. And of course, as you move through the program, that's going to become more diverse depending on what's being presented to you in the clinical space or in the lab. What areas of the body you're going to treat. The frequency and duration of the treatment, number of times per week or per month, whether it's 30, 60, or 90-minute treatments. Anticipated client response, and that includes by when. So you're hoping that by, say, 4 weeks, there's a reduction in their pain, for example. You're going to list the remedial exercises in home care, or maybe when you're doing the treatment plan, you're going to discuss it from the perspective is that will come as we work our way through and I get a better sense of what's going on in your condition or your clinical presentation. Schedule for reassessment, again, 4 to 6 weeks. And again, you're always asking for questions. And of course, then the specific request, do I have your consent for this treatment? So the one thing I want you to do over and over and over again is review this process and practice it out loud. Don't just study it and look at it and never say anything. Find partners, say it out loud, keep doing it. It will become second nature to you. And the only way it becomes second nature if you practice actually saying it loud and doing it. So have a client complete a health history form or create some fake ones. And then, just hand them over to each other without knowing what's on it. Create a health history form and give it to your peer, your partner, or your study group and say it out loud what you think it's going to be. Interview client with intake and pain questions. You want to continue doing that. Consent to assess, practice saying it as I say. The assessment form, use it whenever possible. That could be the observations, assessment findings, and so forth. Sometimes your lab techs, your lab folks will fill one out for you so that you can read it and get a sense of what's happening. Consent to treatment and introduce treatment plan. Again, practice saying it. The treatment. What techniques would you do to meet clients' goals? And talk to each other about that. Talk to your clinic people about that. Get a sense of what works best for what. Develop an ongoing treatment plan with clients. So again, practice out with each other. Consent to treatment plan. Do your consents over and over and over and over again so they become second nature. Home care. Think about it. Try to come up with some stuff. And you've heard me say this in class. Massage therapists are really good at giving stretches, but not great at giving strengthening amongst other things. So start to consider other areas of home care for clients rather than just stretching all the time. Stretching has its place, but what else can you do? And then, of course, you want to always consider payment and scheduling next appointment. When a client leaves, you want to finish those documents, right? Finish out your assessment form, treatment note, plan of care, ongoing treatment plan form. Those are some of the challenges you're going to find when you go into the clinical setting because you have to have these done in a very timely manner when you actually go in and start treating clients in the clinic. So the more you can practice this now, the more efficient you will get at it, and the easier it will be for you to meet the timelines that are required of you when you get into the clinical setting. That's it for this slide set. Thanks. I'll be back. I'll see you guys later this week. I'm feeling a whole lot better, but still got a tickle and a cough, hence the reason why I kept stopping it. There is one other slide set after this. Thanks for giving me the time, and have a great day. Bye for now.